All right, so for this, we're going to start talking about capnography. Okay, so capnography definition is we're talking about exhaled carbon dioxide. We're measuring carbon dioxide that somebody's breathing in or out. So to briefly talk about how capnography is getting our reading and everything, we have two kind of systems. The most common one we're going to use is the nasal cannula. Depending on manufacturer, differs on how it's going to work. One of the more common ones that you'll see is a separate nasal cannula, and you'll sometimes be able to actually see the color difference in them. So one side will be attached to our end tidal measurement going off to the side. The other one over here is going to the oxygen. The other way they can do it is there might be a little slit in here. Okay. And it'll have two little holes and serve the same purpose where the oxygen goes up through here and is expelled, whereas the CO2 can come down and be pulled through the tubing that way. So you have a tubing inside of a tubing. An important consideration whenever you're using nasal cannulas like this is that your oxygen delivery is impaired because of it. Okay, you have a lot of that area is being taken up by the capnography measurement tubing. So even though normal nasal cannula can give you 6 liters, whenever you're using one that's doing capnography, important consideration, you generally can only get about 4 liters. There's some studies that go back and forth on this, just an important consideration whenever you're using these. And there are different kinds and different manufacturers that allow different levels, but this is just kind of generally speaking. The other ways that we can have our ET tube, right? So it would be going down into the patient's mouth and coming here off of the side, depending on manufacturer again. Either you'll have a tiny little small branch that comes off and that would go down to our machine down there. Or sometimes they might have a little plug-in piece that goes right here and serves the same purpose. They'll also use this whenever they're doing intubation, becoming a better and better practice, is a little temporary one that kind of sits into the ET tube and gives them a color reading, so this way you determine whether or not the placement is correct. For the end tidal monitoring though, both of these are going to go to our pump, and our pump is what's going to determine the partial pressure of CO2 in that air. Whenever you do set up an end tidal, okay, the important thing is that we want to zero this piece of equipment. A lot of fighting, in my personal experience, that comes with the end tidal, and the reason people don't like it and say that it's not accurate is because they don't zero the equipment. If we put this into the patient's nose, okay, and they breathe off CO2 into this, we can't zero to the atmosphere out here if we're zeroing to this in here. So if you're zeroing the equipment, it needs to be detached from the patient so we can zero it to the atmosphere, and then we can plug it into the patient so we can see a difference between the atmospheric CO2 and the CO2 that's being expelled. Okay. Some pumps also will need a separate, so they might be unplugged and have to do a pump check as well that may have to be zeroed. Most of them now will take care of that on their own with a little cycle. The only important thing is making sure we zero before we attach to the patient. Because again, we're comparing our levels out here in the atmosphere versus what the patient is expelling. So before we go over how capnography works, we go into how the respiratory system kind of works a little bit and how the respirations work. And so here we have this person, and we have these highlighted blue areas, right? So we have our nasopharynx up here, our oropharynx going into the trachea, into the bronchioles, to both the lungs, okay? And the important concept here to remember is that these whole areas, I'm going to shade these in a little bit, right? All of this here does not deal with perfusion, okay? So all this here, this gas just kind of sits there. It doesn't actually go to the alveoli, where it can perfuse into the blood. So any air that's in there, it doesn't change. There's no carbon dioxide released into it. There's no oxygen taken from it. So that whole area, okay, and this actually goes further down and even into the alveoli, is called the dead space. Okay, and there's the anatomic dead space or physiologic dead space. And anatomic dead space is talking about this whole area that includes this all the way down to the alveoli. And that's just an area, again, where there's no perfusion going on, so there's no gas exchange. The reason that this is kind of important is that as we first breathe out, okay, as this oxygen that we were getting, as we start expelling that CO2, the CO2 is coming from here and it's making our way up. So even though we've expelled all of this air up here, right? So we've expelled all this, we're not going to see a reading or a difference in that CO2 until this air that had started down there makes its way up and out. Okay, so that dead space is going to be that area where there's going to be a little bit different. So there is a lag time whenever we're doing our capnography because of this. Okay. So now knowing that, with our respirations and how CO2 is going to kind of change here, okay, we'll draw this out. So we breathe in. As we breathe in, and if we're measuring right here at, say, the mouth, right? As we breathe in, the level of CO2 isn't going to change from the air, okay? It's going to be just a flat line. There's no change here. We breathe that in, there's no change, no change. We start to breathe out, okay? And we still don't see a change yet because we have that dead space. So there's nothing really going on just yet. As this starts to get up here, okay, as it's trickled its way over, then we start to see the increase, as we measure here, of the CO2 that's being expelled by the lungs. Okay, because as it reaches here, now that level is going to slowly go up as those gases have exchanged. And then it's going to get to a point where it about levels out. So the level that we had down here has finally gone, it's mixed with all this and made its way out. So the level change here isn't going to be much different. It's going to stay at that same level. Okay, and then it's going to get to a point where it kind of peaks out. All right, and then we start our next inspiration. As we breathe back in, that concentration of CO2 here at the mouth is going to drop off rapidly because we're getting no longer the high CO2 that we are breathing out, we're getting the environmental CO2 that's coming in. Okay, so we're going to have this drop off, and then we just kind of continue the cycle. And this right here is our capnography wave. So now we can go and step through that respiratory cycle and start labeling this wave for what each part represents, right? So remember, we had our initial kind of baseline when we're breathing in, and that's going to be stage 1 right here, this first little line, right? So right here, and we'll just call this baseline. Okay, when nothing is happening or we're breathing in. Eventually we get to that expiration, okay? So we're starting to breathe out, and again, we have that trickle, so it takes a little bit. There is that lag effect. Eventually it mixes up nice enough they can come up, and we start detecting it here towards the mouth where we're reading this from. And this is going to be our stage 2, or our expiratory upstroke. Expiratory upstroke. Okay, and that's when the level of CO2, since our lungs are excreting the CO2, that level being detected now at our capnography meter is going to start going up. When it gets to the point that it is balanced out again, okay, so those gases are no longer kind of mixed. Now we're just getting the stuff that was down here at the bottom. That's going to be stage 3, and this is called the alveolar plateau. Alveolar plateau. And then what happens is eventually this gets to the highest point in there, and that's going to be right here. And this is the one that we're paying attention to when we're doing our capnography, because this is called the end tidal CO2. Okay, and that should be the 35 to 45. Then, as we start to breathe back in, that level of CO2 being detected at the meter drastically drops off as it goes back to atmospheric conditions. That's going to be stage 0. And then we just rinse, repeat, okay, again and again and again. So now let's start getting into different kinds of waves and how we can use this for determining respiratory conditions within our patient. The next important thing to look at is knowing how these can change in different physiologic conditions. So even though we normally have a wave like so, right? We breathe in, we breathe out, it comes up, we get to our alveolar plateau, and then it goes down, and then that just kind of wash, rinse, repeat. Okay, like so. So that'll be like a normal wave. Now let's say we had an issue like asthma, or if we had an upper respiratory obstruction here, okay? Let's say they have sleep apnea, for example, okay? Well, what's going to happen is it's going to take longer, right, for that CO2 now, because it has to get past this blockage, so it's going to take longer for it to travel up through the airways. and then get to that peak. Okay, so instead, as we breathe out, instead of it having this kind of sharp rise, it would have a slow rise up. And it's going to get to finally that point where everything is balanced out, and then we'll have our drop off like normal as they breathe in. Okay, this is called it looks like a shark fin, right? This is our shark fin capnography, and this is a sign of some kind of airway compromise or obstruction. And in the cases of airway obstruction, more often we see this with something such as sleep apnea or central sleep apnea. But we may also see it if somebody has, say, bronchospasm, or if they're having an allergic reaction where we're doing procedural sedation inside a cath lab, or if you're in an ICU. Again, really important to look at. The other option is if we had a complete obstruction of the airway, such as complete obstructive sleep apnea in this case. They pass out and drugs are kicking in nice and good. They start taking a nap, their airway closes off. We're going to see that wave, okay? And we're not going to see anything because no air is getting out, right? And it's going to stop for a good while, and the next time they breathe out or they manage to finally clear that airway, we'll probably see a little bit of an upstroke, and it's going to be much taller because, again, they need to dump off more CO2 in that case. Okay, and that's when we're going to see one of those physiologic responses again, as the CO2 is building up in the lungs, needs to be kicked out. So you'll see a higher end tidal CO2 in that case. So as we look at our end tidal, we'll start seeing waves that are more like this, and it'll be drawn out again and again as it's repeating. So one of the more useful things we can use this for, obviously, is just counting respirations, right? So we can just visually look at this, or we can go end tidal to end tidal. So we'll go this point to this point, and we just count the distance in between there, right? And our machines are good about calibrating for this, and will give us a respiratory rate going off of this. So if we see these, averaged out, should be that 12 to 20. And then our end tidal here, okay, is going to be 35 to 45. So I'll write this down up here. So our normal respiratory rate is going to be that 12 to 20. And our EtCO2 is going to be 35 to 45 millimeters of mercury. Okay. So if we were to put a line here about that 35, 45 right here, is where that should lie in between, as long as we have a normal respiratory rate and nothing's really going on. Now, if our respiratory rate was to slow down past that 12, okay, then we're going to see the end tidal is going to go up. Our body still needs to get rid of that CO2, and if it's not breathing as fast, it needs to offload more of it. So what we'll see with a slower respiratory rate that is less than 12 is that this end tidal will go up. If we're outside that norm, the end tidal should also be outside that norm. So in this case, we could have an end tidal of, say, 50. Okay. So this wave would get taller and probably a little bit broader. Okay. And that's if they're slowing down their respirations. Because again, if you had a couple bushels of apples and you need to get rid of them, people aren't buying them as much. You need to sell them more in bulk. The lungs are going to do the same thing. They're going to get rid of more and more CO2 with each breath than if we were breathing at that normal 12 to 20 rate. Conversely, if they're breathing really fast, that end tidal should drop down. Okay, so if we had this same level up over here, we'd see the end tidal rate, or the end tidal measurement, should drop down because they're breathing faster and faster. And then with that, we would see shorter, smaller waves. Okay. So this is where the end tidal will be very, very useful, especially in procedural sedation areas where we're looking at their airway and their overall respiratory function. It gives a very quick look at that respiratory function. If we're seeing respiratory rates or end tidal rates that are outside the norm, we have to go and look at everything else, right? It would be a bigger issue if we're seeing an end tidal outside the norm with a normal respiratory rate, or if something's moving in a different direction. That can mean we have some kind of imbalance, such as a respiratory acidosis, metabolic acidosis, etc. And that's the point you'd start moving towards ABGs and kind of narrowing down what's going on. So another thing I want to talk about briefly here is what we'll commonly see, especially if you're doing procedural sedation on patients, is going to be something called Cheyne-Stokes breathing. Okay. So there's a couple different breathing patterns. We have Kussmaul's respirations, Cheyne-Stokes respirations, Biot's respirations. Biot's and Kussmaul's are something you'd see in Kussmaul would be like a metabolic acidosis, where you'd see like DKA. Biot's breathing would be something that is a nervous issue you see in like the neuro ICU. Cheyne-Stokes, though, particularly in the cath lab IR, especially where we're doing anywhere procedural sedation, is going to be a lot more common. And what this is, you're going to see the waxing waning. This is particularly seen on the end tidal, where we'll get our initial wave here, and they're going to breathe in slower and slower. So our end tidal is going to slowly rise up, and these breaths are going to get longer and longer, right? And then they're going to wane, because what happens is they breathe this off, and then there's going to be a pause. So eventually it'll go down. They'll stop breathing for a bit, and then you see our breaths will stop. And that's the point that the respiratory system decides, hey, it's time to wake up, and you'll see it kick back up, right? And these will get bigger and bigger each time as they expel more air and those respirations increase. So this is just a common thing that you'll see, and it's can be a nifty way to gauge where your sedation at if you're progressing from the area of safe procedural sedation going into the area of deep sedation, where you're going to need to do more airway management. One last important consideration I think is personally just really underutilized, and is one of those areas where this can come really in handy, is if you have a crumping patient, okay, or you're coding somebody, you can monitor that end tidal as you're bagging them. And you're going to see, say, whenever you're giving those breaths with a BVM, the level of the end tidal here is directly kind of corresponding to the perfusion, right? If the lungs are able to perfuse CO2 and oxygen and the heart is pumping blood, that end tidal should be that 35 to 45. If we're not effectively pumping blood or doing that perfusion, we're going to be much further down there. So end tidal is becoming more and more of a tool for gauging the effectiveness of CPR, and if there's even a point in really kind of continuing, right? Because if we're sitting here and we're getting an end tidal measurement of, say, 5, right, that means we're not getting enough perfusion. Unfortunately, either our CPR is not good enough, or maybe our efforts just aren't doing enough. However, what can eventually happen if you are monitoring your CO2 like this and you have that capnography waveform is all of a sudden you're going to see a giant spike, okay? So you'll do the BVM one of these times, and all of a sudden it's going to shoot on up. It'll probably be like 50 or something, right? And this here is a sign of ROSC, okay? So that can indicate that our perfusion has suddenly gotten to the point of being good enough, either because the heart has kicked back in, or maybe we put in a device or something to the point we finally have the return of spontaneous circulation. So this is a really useful tool if you're ever having a coding patient, a crumping patient, anything of that sort, to this way be able to manage their perfusion quite simply by just adding on the capnography.